Hello, Bree.
Hi.
Thank you for joining us. We're live with our group, and thank you for beginning our webinar.
Would you like me to get started or?
Yes, please. Thank you.
Okay. All right. Well, I'll start by saying that athletes of all ages across all sports are at risk for injury, but there are some injuries that are unique to the growing athlete. So today I'll be reviewing those aspects of the musculoskeletal system that are particularly vulnerable for injury during rapid periods of growth. So I want to try to help you identify when these might be affecting your athletes, what to expect in terms of treatment, and ways that we might be able to prevent their occurrence or at least reduce their impact on gymnastics participation. I'll start with an overview of what makes the child and adolescent skeleton different from the skeleton of an adult. And then I'll go into the 4 main types of injuries that are unique to the immature skeleton. This includes Salter fractures. Salter fractures are a classification of fractures that only occur through a growth plate, so that's what makes those special. Apophysitis refers to inflammation of an apophysis. An apophysis is a growth area as well, but it's special because it's like a protuberance or a part of the bone that sticks out. And this is where soft tissues attach. Most of the time, we're talking about where tendons from muscle attach to bone as the apophysis. So inflammation at that site can come from an active period of growth or from a muscle that's pulling through its tendon attachment there over and over again. There is also a type of spine fracture that happens only in the adolescent spine. This is different from the Salter fractures because it does not involve a growth plate. It's just a part of bone within the spine that is particularly vulnerable in adolescence. And then finally, we'll talk about OCD lesions. These are injuries to cartilage, and cartilage is that slippery, smooth, but resilient material that covers the ends of bones where they meet to make a joint. Technically, adults can get OCD lesions as well, but adolescents seems to be particularly vulnerable for that injury. And Lorraine, I can't see the screen, so are you now on slide 7?
Yes, I'm on slide 7. I'm following you along.
Perfect, thank you. Okay. So first, let's talk about how the growing skeleton is different from the adult skeleton in more ways than just size. So when we're developing in the womb, our bones begin as cartilage, and it's represented here in this picture in blue. During the 8th week of development in the womb, that center of the cartilage model starts to change. Basically, the outer perimeter covering of it starts to get very hard. It starts to accumulate a lot of minerals like calcium. And in the picture, it's tan. Then later, blood vessels will start to grow within the bone. These vessels nurture the bone and support the constant remodeling that will actually persist throughout life. During childhood, the hardening process will continue in the center of the bone, and then later, it'll start to harden on the ends of the bone. We call these the secondary sites of hardening or ossification. So then this creates a zone of cartilage that is sort of sandwiched between 2 areas of hardening bone. These zones of active growing cartilage add to the length of bone over time and are commonly called your growth plates. So in the picture, it's that blue area that's sort of in between 2 tan areas, the tan areas being the hardening bone, the blue area being the cartilage that's still growing. Eventually, as we reach adulthood, those growth plates will also harden too, and so the whole bone will be mineralized and hard, which is what you see all the way to the right. When we look at a still developing bone on X-ray, this is how it'll appear. This is an X-ray of the wrist. The wider bone on the right side is the radius. This is one of the 2 bones in your forearm, and this is on the thumb side of your wrist, the radius. do you see that black line or space that's running horizontally across the top portion of the radius? That's the growth plate. That's the zone of cartilage that's still active and creating length in that bone. Now, cartilage doesn't show up on X-ray because it's not hard like the rest of bone, and so it's technically a soft tissue, so it looks more like a gap or a space on the X-ray. It's not really a space, it's just where soft, active growing cartilage lies. In the medical world, we call that growth plate the physis. Then there's a section of hard bone just above the growth plate, and this is called the epiphysis, and that root epi in Greek and Latin means on top of. Now there's actually a layer of cartilage again on top of the epiphysis, and that fills up the area that's labeled on the X-ray as the wrist joint. This cartilage is a little different from that cartilage in the growth plate. Its purpose is not to grow, but instead to create that smooth, slippery surface over the end of bone in the joint. The small bones after the end of the radius are completely wrapped in this kind of joint cartilage as well, and that's what fills all the dark spaces on the X-ray. Now here we have a comparison of a still developing wrist with open growth plates on the left and an adult wrist on the right. So notice that the adult wrist on the right, those bones don't have any of those horizontal gaps or dark lines that go across. And that's because the growth plates, or the physes, have completely hardened. Now we see that there's still spaces in between the bones, and that's because these bones are wrapped around or covered in that joint cartilage. Now, if a patient develops arthritis, that space will eventually wear down and go away, and the bones will appear like they're much closer together. The growth plates that growing kids have do leave their bones a bit more vulnerable to fracture. In fact, when it comes to sports injuries, kids are a lot more likely to break a bone than to tear a muscle or a ligament. There are different fracture patterns that can happen in immature bones. These fractures are classified as Salter-Harris, or sometimes just called Salter fractures. The most common pattern I see in gymnasts is the type 1, although I do have a theory that some of my type 1s are actually type 5s, which is kind of a crush or compression type of fracture. If you look at all kids across all sports, the most common type of fracture is a type 2. Back in the type 1 and type 5 fractures, the injury is through the growth plate itself. This actually makes it very difficult to detect on X-ray, because remember, that growth plate looks like a blank space on the X-ray. So we have to make a diagnosis based off of the athlete's story, their symptoms, the exam, and then just proof on the X-ray that they even have open growth plates and that there's no other fracture pattern seen. The most common place I see Salter fractures in gymnasts is in the wrist at that radius bone. And it can happen in one of two ways. In one way, the gymnast develops wrist pain gradually, and it increases in severity over time until he or she can no longer do normal training. This is where I believe gymnasts are actually developing a stress type of fracture from repetitive compression and impact. That would be a Salter 5. Their X-rays oftentimes will look normal. The only time I've seen an abnormal X-ray in this case is when their issue has been particularly chronic. So when an athlete's been pushing through the pain for many months. In that case, the growth plate will actually look a little extra wide. That space will look extra wide on an X-ray because the swelling and bleeding within the growth plate makes it bigger. The other way that gymnasts can injure this growth plate is with a single injury or incident, like coming in too low and flat on a Yurchenko entry, or maybe coming down awkwardly on the hands during a back handspring on beam. In this case, there is an acute injury to the growth plate that basically tilts and pulls it apart, almost like if you can imagine a peanut butter and jelly sandwich and peeling off one slice of bread, with the growth plate being sort of the peanut butter and jelly center, and the slices of bread being the hard bone on either side. These X-rays can look normal as well, but they can also show a widening of just one aspect of the growth plate, confirming that sort of tilting and pulling apart effect. When that happens, that's called a Salter 1. The other place on the body where I see Salter fractures are at the ankle. When an athlete rolls her ankle this way, the ligaments are very likely to be sprained. But in a young developing athlete, he or she may also injure the growth plate at the bottom of the fibula bone. The x-ray on the right is an x-ray of an ankle. The skinny, long bone on the left side of the image is the fibula bone. At its end, you can see an open growth plate, which is that dark line or space that runs left to right. Now, do you see how the leftmost aspect of that space or growth plate is wider than the rightmost aspect? So this is that Salter 1 fracture of the growth plate where there's a bit of widening. It can be tough to differentiate this from a bad ankle sprain without an x-ray, though in most cases the x-ray isn't abnormal. It takes a knowledgeable physician in sports medicine or orthopedics to kind of pick up on the signs for this fracture. So in review, Salter fractures are a special class of fractures that involve growth plates. In gymnasts, I see Salter fractures most commonly at the wrist and ankle. In the wrist, the fracture can happen either with repetitive impact over time or with one single bad impact or jam. One key in differentiating this injury from other sources of wrist pain is determining where the athlete feels the most pain on the wrist. The growth plate of the radius is basically right where the strap of your watch would go across your wrist. So if a gymnast points to that aspect of her wrist, it's a good idea to have a sports medicine physician evaluate it. At the ankle, a Salter fracture to the fibula bone can look a lot like a bad ankle sprain. Most of the time, these injuries will show much more pain, a little higher swelling, a slower recovery compared to your typical sprain. So I'd keep this in mind if you have a skeletally immature athlete who has pain or dysfunction that just seems out of the norm for your typical ankle sprain. Treatment of any bony injury requires some element of immobilization or holding it very still and rest. This is the hard, unfortunate truth of bony injuries. Muscle injuries we can usually train through to some extent while rehabilitating them, but bones need to be held still and protected to let our immune systems take over and get the job done as quickly and completely as possible. After a period of immobilization or holding it still that could last anywhere from 4 to 6 weeks, the doctor is going to wean the athlete out of the cast or splint or boot to ensure that non-athletic activities are pain-free first. At the same time, athletes should work on regaining their normal motion and strength through that joint that was just held still for 4 to 6 weeks with rehab exercises. Then a gradual return to gymnastics begins as the rehab exercises are progressed to maximize strength and stability. One aspect of Salter fractures at the wrist I want to highlight is their potential for a serious complication. If the growth plate at the radius is injured and not treated properly, it will ossify or close prematurely. But remember, there's another bone in the forearm right next to it. That's the ulna. If it was not injured, it's going to keep growing. So then you can have a situation where one bone is actually a little longer than the other. This is called positive ulnar variance. This can be devastating for a gymnast. That long ulna can tear up the soft tissues on the pinky side of the wrist, in a tissue specifically called the TFCC, to the point where the athlete can no longer really trust the wrist for support. The only treatment for this situation is surgery, and it's expensive. A section of bone must be cut out of the ulna to shorten it, and then hardware has to stabilize the freshly broken bone, while that TFCC tissue has to be either removed or surgically repaired. This is why I tell my coaches, especially my men's artistic coaches where I see this, to please let their kids that have pain at that watch strap area of the wrist get checked out. If we can get the growth plate on the radius to heal normally, we can avoid this very complicated situation in the future. The ankle Salter fracture has fewer propensities for bad outcomes, but just understand that since it is a bony injury, it is going to take a little longer to heal than a simple sprain. The good news is with these ankle injuries, when treated appropriately, they don't tend to lead to chronic instability like bad sprains do. It's one of those rare cases when I almost hope an athlete has a bony injury instead of a ligament injury, because the outcome here is so much better in the long term. Certainly, we would like to prevent these injuries, no matter how good or bad the outcome, from ever happening. When the injury happens from a fluke accident, like a jam to the wrist or a turn of the ankle, there really isn't much we can do to prevent that. But for the chronic wrist injury, or for the ankle that already has a history of sprains, we do have some control over risk. I find that gymnasts who maintain the most shoulder and upper back flexibility while still maintaining good activation of the small muscles that control stability from shoulder through to fingers are the least likely to have wrist problems. When you look at this picture of gymnasts in bridges, you will see who has more and who has less shoulder flexibility and how that influences stress through the wrist. The gymnast with the blue shirt has excellent shoulder flexibility that allows her to have her shoulders aligned right over her wrists, and her wrists are only extended about 90 degrees. Further back in the picture, where we see just the top half of a gymnast in a black Leo, her shoulders are not quite over her wrist, and she has a more closed shoulder angle. Her wrists have to be extended then beyond 90 degrees, which puts a lot of excess pressure through the bones. If you have a gymnast who has rolled her ankles before, if you've identified maybe one of those loosey-goose types of gymnasts with a lot of natural flexibility, you may be able to prevent an injury by taking time to train better stability. You can do this with exercises that strengthen the small muscles of the arch of the foot and by practicing balancing exercises on one foot on various surfaces. Again, fluke accidents and acute injuries can be very difficult to prevent. The areas of stiffness or weakness in a gymnast can make it more likely for them to develop an overuse injury compared to a gymnast that has just the right balance of joint mobility and stability. Now we'll move on to the next injury type that's unique to growing athletes, apophysitis. I mentioned earlier that apophysitis is inflammation of an apophysis, which I understand does not do much to explain what it is. So again, an apophysis is a part of bone that sticks out from the main body of the bone, so it can be an attachment site for some soft tissue, most of the time a muscle tendon. We all have these attachment sites, these apophyses, but in a skeletally immature kid, this attachment point is separated from the main body of the bone by a zone of growing soft cartilage. So here in this diagram of a knee, there is something called the tibial tubercle apophysis. This is a bump on the front of the knee just below your kneecap. It's an attachment point for the tendon that comes from your quad muscle in your thigh. When your quad contracts, it shortens, pulling on the tendon as it attaches to this bump, and your knee straightens out or extends. Because the attachment point is separated from the main body of the bone by a soft zone of growing cartilage, represented here as a gray line, repetitive tugging at this site from a lot of jumping and landing can pull at that soft zone of cartilage, making it very inflamed. When this happens, it's called Osgood-Schlatter's disease. This is the most common overuse injury in all adolescent athletes. It can happen in one knee or both, and the peak time for seeing this is age 13 in boys and age 12 in girls. The knee may have a focal area of swelling right over that tubercle, like in the picture on the left. On an x-ray, we can see that soft cartilage zone as a dark, sort of blank space over the front of the knee. The quad's tendon attaches to that overhanging piece of bone on top of that blank space, and that's technically the apophysis. This is a pretty normal appearing x-ray in a patient who is still growing. Sometimes that tugging stress can be enough to fracture a piece of the apophysis and pull it away. This phenomenon can happen in all kinds of places throughout the skeleton. There are many places where a tendon attaches to bone directly over an area of growth. At the hip, the large wing-shaped bone called the ilium has a long round rim to it called the iliac crest. There are many muscles of the core that attach here, and that entire rim is an apophysis. It's actually the last bony part of the body to mature or harden, and that doesn't happen until age 20. The left and the right ischium are parts of the pelvis where we sit. We sometimes call these our sitting bones. They are also the attachment sites for our hamstring muscles. As you might have guessed, they have open growth plates right where those hamstrings attach. So gymnasts with ischial apophysitis can act a lot like a hamstring strain, but their symptoms will come on gradually, and their pain will be focused very high up on the hamstring where they sit. At the knee, an athlete can develop apophysitis down at the tubercle, which we already reviewed as Osgood-Schlatters disease, but there's also a growth center on the bottom of the kneecap. If this becomes inflamed, it has an even better name. It's called Syndig-Larsen-Johansson's disease. Then probably the most common site of growth inflammation that I see in gymnasts is at the heel. This happens where the Achilles attaches to the heel bone right over, you guessed it, a growth center. And this is called Seaver's disease. It tends to cause severe pain along the back of the heel, sometimes wrapping around the sides of the heel slightly, and it's usually worse with impact or any direct pressure to that area. Finally, the last site I'll mention, because I do see it quite a bit in gymnasts and it can be hard to diagnose, is Iceland's disease. This is inflammation of a growth center on the outside of the foot, specifically at the base of the fifth metatarsal, which is where a muscle of the calf attaches. This tends to be most painful when gymnasts need to push off through the foot, like when they're sprinting or when they're lifting up into a calf raise or releve position. No matter where on the body an apophysis becomes inflamed, it'll generally act the same way. The pain may come and go depending on whether the athlete's in a period of rapid growth. It can certainly be influenced by activity level as well, getting worse with more strenuous activity to that area of the body. It may act a little bit like a muscle injury in that the athlete can reliably reproduce the pain when using the muscle that attaches there or really stretching the muscle that attaches there. But the difference will be that the pain is focused to just that insertion point on the bone. The pain won't be all the way through the length of the muscle. Swelling may be more obvious in certain areas of the body, like over the knee in Osgood-Schlatter, on the side of the foot in Iceland's, but it's not very obvious if it's over the hip bone or at the heel. Because the same general process is at play, treatment follows a similar pattern for each site. Oftentimes, pain becomes so severe, it is necessary to modify the gymnast activity to ensure that his or her compensation or favoring doesn't cause worse injury. Coaches may need to reduce impact using a trampoline surface instead of a regular tumbling surface, for example, or do more flat-footed activity in, say, rhythmic gymnasts with Iceland's disease. And then frequent, and I mean every other hour for 15 minutes at a time frequent, icing can make a big difference in pain by reducing inflammation. Usually there is a bit of tightness in the muscle that attaches to that inflamed growth center in apophysitis, but pulling and tugging on that muscle even more in aggressive stretching may do more harm than good, in my opinion. I usually recommend instead using foam rolling, ball massage, massage therapy, gentle stretching to get that muscle to soften and release. Poor mechanics is almost always a contributing factor to apophysitis. In kids with Osgood-Schlatters and Seaver's disease, I usually find weakness in the hip muscles, like in the glutes, and in the ankle or stabilizer, arch stabilizer muscles at the foot and ankle. These kids will often land with a knocked knee or a flat foot sort of position. So while I always recommend that we modify activity and we ice and we loosen up the tight muscle, it's the correction of the poor mechanics that probably makes the biggest difference in reducing pain and really keeping it away. There are a lot of products out there marketed for apophysitis, particularly for Osgood's and Seaver's. The theory behind these is to try to take the traction and place it somewhere else. Like with the knee strap above, the quad tendon will pull more where the strap puts pressure across the tendon, which will then give it a little bit of slack at its insertion on the bone. The theory behind the heel cup is not only to pad the sore area, but to sort of lift up the heel a little bit, which takes up some slack in the Achilles tendon in Seaver's disease. This can certainly help give immediate relief, but it can become a problem in and of itself if it's used for an extensive period of time. It can actually shorten and then stiffen the Achilles, which could make the problem worse or even harder to treat. So I only recommend heel cups for those kids with extreme pain as a short-term pain reliever. When I talk with parents of kids with apophysitis, I explain that we are largely at the mercy of their growth and development when we're trying to improve their pain. I'm not going to take any efforts to stop or slow their growth just to reduce a kid's pain from apophysitis. This is obviously a joke. So evaluating this condition early and getting inflammation treated before it becomes out of control can go a long way in limiting how much this actually interferes with gymnast training. Identifying and resolving those mechanical errors, such as the knock-knee landing position I talked about, is probably our best bet in preventing apophysitis. So if we see that poor landing position, we need to correct it, just like we would any other skill technique. Now, we may also need to consider adjusting technique or change it slightly, not because it's wrong or incorrect, but because it could contribute to injury if done a certain, even technically correct way too many times. Now, I know I'm towing the line between medicine and coaching here, but bear with me. So see this picture of a male artistic gymnast, very happy about his vault landing. So look at his position. His landing position is one that sports medicine doctors like myself dream of. I can't see his feet, but I'm going to assume that they're pointed straight ahead. His knees are bent a healthy amount and are exactly wide as his hips, which allows them to bend directly over the tops of his feet and not collapse inwards towards the center of his body in a knock-kneed position. His hips, and this is my favorite part, are beautifully bent. This amount of sitting into the hips is the best way for his legs to absorb big impact. Without this bend in his hips, his low back, the front of his knees, the backs of his ankles are going to take way more stress than they were designed to take. Now, I know that some of you will say that, oh, his feet might be too far apart, his hips might be too bent, his chest too low to get a perfect, no deduction landing according to the code. And there are probably even other parts I'm missing there. But what I'm asking you to consider is this. Your gymnast has to land on a relatively stiff surface at competition, but you don't have them land on this surface with every single repetition in training, right? You use 8-inch mats, resi pits, trampoline surfaces, air track devices so that your gymnast can get numbers without all the pounding. I'm proposing that we limit that pounding with more than just changing the surface, that we train gymnasts to absorb impact in healthier positions through their bodies. Just as we start introducing the landing mats closer to meet time, I believe in our gymnasts' ability to adjust their landing positions for competition as well. That concept is probably something I could spend an entire webinar talking about, and it's fielding very passionate counterpoints from coaches, but I'm content to just plant that seed in your brains for now to meditate on and consider. Aggressive stretching techniques, such as oversplits with pressure that's then applied by a coach or a teammate, may also contribute to the development of apophysitis. I see this phenomenon most often at the hamstring insertion on the bottom of the pelvis. Now, I'm not saying that we have to discard this approach to stretching entirely. I'm just suggesting that some athletes going through rapid periods of growth may be vulnerable to injury when we use this technique. So I'm suggesting that coaches consider other strategies for improving flexibility. I have not found any head-to-head study that compares different stretching techniques and their potential influence on the development of apophysitis specifically. I just want to list other possible flexibility training options that allow the individual athlete to control the amount of traction that she actually puts at her growth plates. So the other options we have are static stretching on her own, so without the overpressure from a coach or teammate, dynamic stretches such as in leg swings and kicks, swinging movements, and PNF stretching, which is where an athlete gets into a position of feeling a stretch, then contracts those muscles against the floor of the wall, and then releases again to a greater range of motion. My preference, for which I don't have a whole lot of literature to back up, would be to use dynamic stretches during the warm-up period, and then your PNF stretching at the end of practice to gradually improve range of motion without putting undue stress at the growth plate. Now we'll move on to a type of fracture in the spine that only happens in adolescence. In fact, this stress fracture, called spondylolysis, is statistically the most common cause of low back pain in all adolescents, regardless of sport. The stress fracture happens in a small section of bone off the back of the large, boxy vertebral body called the pars interarticularis. This is a small arch of bone of which there is a left and a right pars off of each vertebrae, and it's very vulnerable to stress in growing kids, particularly your preteens and teens. It's loaded or compressed when the back is arched. That loading and pressure will soften the bone at first, and this is called a stress reaction. Eventually, it will become so soft that it finally breaks, and that's your stress fracture. The potential complication, if both the left and right pars fracture, is that the vertebral body then can subsequently slide forward out of alignment with the rest of the spine. This complication is serious, and it can pull on the nerve roots that come out of the spinal cord. That sliding forward is called spondylolisthesis. Athletes that develop a stress fracture in their spines usually have a gradual onset of low back pain that's located in the center of their back, low, right over the spine. It'll be predictably worse with arching or extension. As it progresses, it will become painful pretty much no matter what the athlete is doing. They might have pain with standing for a long period of time or even just sitting in class at school. When I evaluate an athlete with back pain, I start by asking how the pain started, where on the body they feel it, what makes it worse, and what makes it better. There are special tests that I can do on a physical exam that will either reassure me against a stress fracture or make me more concerned for that diagnosis. In those cases, I start with a plain x-ray of the spine. Many times these x-rays will be normal, so advanced imaging is usually necessary. Now, this is an area of active debate within the medical community. If you live in an area with access to a CT SPECT scan, this is the preferred imaging type to make the diagnosis. In my area, an MRI suffices to make the diagnosis, but then I use CT scanning for follow-up images. So I just want you to be aware that different physicians in your area may order different tests. There is more than one way to make the diagnosis. Folks, this is not a great injury to have. There are only two injury scenarios where I have to completely rest a gymnast initially: concussion and a stress fracture in the spine. The reason we have to completely rest a gymnast or any athlete with this injury is that fractures in this part of the body are different than fractures in bones of, say, the leg, for example. If you break a bone in your leg, we can cast it and we can completely offload it by putting you on crutches. But we don't have that luxury with the spine. It's very difficult to immobilize it, and it's nearly impossible to offload it. So we have to be aggressive with rest. Just standing, sitting, turning over in bed, these are all stresses to the spine that can interfere with healing. So instead of laying a kid up in a hospital bed in a full body cast, we rest them from sport. I also use a brace for the first 3 to 6 weeks to keep the spine supported and as still as possible. But please be aware, this is also an active area of debate within the medical community. So there are some physicians in your area that may use bracing, some may not. But the rest from sport and that initial phase of recovery is absolutely the standard of care. Rehab with the right therapist can start right away. There are muscle activation exercises that can begin the process of better stabilizing the spine without actually putting any movement through the spine. So think like plank hold type exercises and variations of those. Over a period of at least 3 months, bracing will be weaned away, rehab exercises will progress towards more fitness type movements, and a gradual progression back to sport will then follow. Follow-up imaging of various types will be done to monitor bony healing. The most important component of recovery and rehabilitation in this injury is the identification and correction of the mechanical issues that caused this fracture in the first place. Now, I said that this was the most common cause of back pain in adolescents, but there are certainly many, many gymnasts that never develop this fracture. So why are some so unlucky? Well, some must put more stress across their spines than others, even while doing the same skills. The common pattern I see in gymnasts with this injury is one where their shoulders and upper back are very stiff, their hip flexors are tight, and the lower abdominal core muscles are weak. This again is a topic I could spend an entire webinar discussing. If I had to pick one test that you could use to see if an athlete has risky mechanics, and that's a very hard thing for me to do, I would use what is called the prone hip extension test. So in this, you have your athlete lay flat on their belly, and you're going to have him place his hand under the bony part of the front of his hip, so that his hand is basically between the floor and his hip. And then you're going to ask him to lift that leg straight, just a couple inches off of the floor, like a heel drive, but with a single leg slowly. If that hip bone presses down into his hand when he lifts up the leg, he is using poor mechanics that are stressful to the lumbar spine, and he's probably using those same mechanics every time he drives his heels or pushes off with that leg. Good core control and proper muscle firing patterns should result in an athlete stabilizing the hip, keeping it up, not dumping it down, and then lifting the leg up. An athletic trainer or a physical therapist that's skilled in this type of assessment can help correct the pattern and protect your athlete. Finally, we'll talk about our last injury type, OCD lesions. This is a cartoon image of an OCD lesion in the knee. OCD in this case stands for osteochondritis dissecans, and you can think of it as like a pothole that can develop in the cartilage surface over the end of a bone. You can also think of it as almost like a stress fracture of the cartilage. They occur when the cartilage suffers repetitive high impact and stress. The cartilage will soften first, then it'll indent or kind of cave in, and eventually it'll fall apart, a lot like loose gravel in a pothole. These injuries can occur in any joint, but the most common joints to find them are the elbow, knee, and ankle. Over all sports and all athletes, the knee is the most common location for an OCD lesion. But in gymnasts, I see them quite a bit in the elbow and the ankle. Athletes will typically have a gradual onset of pain, then a more sudden worsening or more severe pain once the stressed part of cartilage starts to fail. They will complain of pain at the joint, not at a muscle, that worsens with any impact or pressure. When the joint is particularly stressed, like with a short landing on an ankle, it will swell. If the OCD progresses to that loose gravel stage, it can create sensations like locking and catching of the joint. When I see these patients in the office, I start with just gathering a story of their symptoms, because joint pain can be explained by a lot of things, but if they have an area of pinpoint extreme pain that's worse than any pressure or weight bearing, and especially if they have any locking or catching, I'm thinking about an OCD as a possible cause. I'll look for that pinpoint area of pain along the surface of a bone on exam, and if I can reproduce any of the catching. X-rays can show evidence of an OCD, especially if it's advanced, but oftentimes an MRI is needed to confirm the diagnosis. A CT scan sometimes is needed too if there's a loose body suspected. The treatment for OCD lesions depends quite a bit on how advanced or severe it is at the time of diagnosis. At a minimum, the joint needs to be immobilized to hold or to allow the immune system to heal the lesion. If there are loose bodies or an impending loose body, like a loose tooth appearance on imaging, then surgery really is the best course of action. After that period of immobilization or surgery, the athlete will undergo a period of rehabilitation to get back normal motion and stability and to correct the mechanical factors that led to the excess stress at that joint. Injection therapy is a topic that'll come up in these cases on occasion. This includes steroid injection therapy, which reduces inflammation, but it doesn't actually heal the lesion, as well as PRP, which stands for platelet-rich plasma. This type of injection induces a healing response, and it may help regenerate lost cartilage in OCD lesions, but this is still considered experimental by the FDA, and it's an area of expansive research. The main factors leading to OCD lesions are the volume of impact to the cartilage and the mechanics of how that cartilage is exposed to trauma as part of the bigger musculoskeletal system. So it logically makes sense to monitor both loading and mechanics. Especially at the competitive level, I believe it's prudent for coaches to track the amount of hard landings and repetitions on the least forgiving surfaces your athletes endure. And then, in accordance with the lessons that Dr. Bill Sands has provided us on periodization of training, we need to allow for reduced loads after periods of increasing loads. Basically, we need to insert times of relative rest from impact between times of high impact and loading to allow many of the body's tissues to recover and become more resilient for the next round of hard training. The pattern of mechanics I find most associated with OCD lesions in the elbow is one where the gymnast tends to hyperextend the elbow when they're in support. If we can identify this early in a gymnast training and correct it by teaching the gymnast how to stabilize in the true straight position instead of locking out hard past straight, we are helping her to put pressure through this joint as it was designed to take it. At the ankle, I see OCD lesions most commonly in gymnasts with a history of many short landings and relative tightness through the calf and Achilles. Monitoring for stiffness of the joint in that flexion, making sure to improve flexibility of those calf muscles to allow for more normal joint mobility, gives the ankle a greater margin for error in a short landing. When short landings do occur, I would encourage coaches to consider going back to a drill to correct the problem or change the landing surface until the landings are consistently more upright again. With each short landing, we greatly increase the chances of seeing an OCD lesion in the ankle. And finally, like any overuse-related injury, the earlier it's detected, treated, and corrected, the less time your gymnast will miss, and the simpler their recovery strategy. So that was a lot of information to cover. We reviewed what makes the bones and joints of a developing athlete different from those of an adult. We talked about the 4 injury types that are unique to immature skeletons, including Salter fractures like gymnast wrist, apophysitis like Osgood-Schlatter's and Sievers, stress fractures in the spine, and OCD lesions or cartilage potholes. In any case of injury, when an athlete's pain persists beyond 10 days and beyond the gym door, it's a good idea to get it checked out by a sports medicine physician. Compensation and limping can lead to worse injury, and so this is another reason to seek proper evaluation and treatment. The location of pain can help you differentiate between normal soreness from training and true injury. For the growth plate injury at the wrist, the pain is felt at approximately the same place a watch strap would lie across the wrist. For apophysitis and OCD lesions, the pain tends to be pretty pinpoint right on a bone. Expect athletes to have some steps to their diagnostic workup. Immature bones can make diagnosis a little trickier. Sometimes we have to use advanced imaging like MRI and CT. Also, these injuries might be beyond the scope of a primary care provider and warrant evaluation by a sports medicine physician. When the injury is in the bone or cartilage, it needs to rest. It's hard to swallow, but a simple concept. No amount of taping or medicine or therapy heals a bone. Our immune system heals bone, but it needs a stable, protected environment to do the job best. You probably picked up on a theme of mechanical factors being important in these injury types. This should be a part of every injured athlete's assessment and treatment plan to keep injuries from coming back. Growth periods are stressful on the human skeletal system in and of themselves. We may need to modify loading and consider changing some of the training methods as they pertain to impact and stretching to accommodate or offset this stress. And finally, prevention. Prevention is always and will always be better than treating an injury that has already happened. Again, track the loading you put your competitive kids through. Make sure you are using periodization to build strength. To build strength and ability, not just a steady, linear increase in intensity over time. We have to allow for recovery in order to build true resilience. Look for the common mechanical problems that can lead to the injuries we just covered. And lastly, consider different flexibility training strategies if your kids are complaining of pain at these bony insertions for their muscles. I'm grateful for the opportunity to share this information with you all. and I'm looking forward to taking your questions.
Thank you, Dr. Simmons. If you have a question, you can email us at clubservices@usa-gymnastics.org. Thank you for your time, Dr. Simmons, and everybody that participated today on our webinar.